Terima kasih, Dr. Farid Kumiawan, Dr. Trajuli Tarigan, and to our chairperson, Dr. Mata Rosan. My topic today is prolactinomas in men and women, issues, problems, and solutions. What I propose to do as the target of my lecture would be to discuss firstly prolactin physiology, pathophysiology, and then move on to the clinical presentation, highlighting the differences between men and women, and then talk about how do we make a diagnosis and what are the traps we must be careful about. After that, I will move to management decisions, how we decide. I'll discuss a little bit more in detail on medical treatment, touch upon resistance and surgery, and a little bit about radiation. Subsequently, I will move on to the subgroups with prolactinomas, those in pregnancy, menopause, multiple endocrine neoplasia, children, psychiatric practice, malignant, amongst others. And finally, I will round up with summary. Time permitting, we can discuss some cases. Let's first talk about prolactin physiology. Prolactin is controlled by inhibitory hormone dopamine, which comes from the cells that are more in the posterior part of the anterior pituitary gland. There is also a stimulatory hormone control from thyroid releasing hormone, TRH. And estrogens stimulate I have not shared.
I'm sorry, Prof. Raja, you haven't
Yes.
shared your screen.
I did, but somehow it came off. Okay, let's try.
Yeah,
Is that better?
yeah. Now the screen is shown. Thank you.
Okay, so TRH stimulates it. Dopamine is an inhibitory hormone. Estrogen stimulates the lactotropes. Wow. And prolactin is secreted by the lactotropes. This undergoes metabolism, and therefore in liver disease, prolactin can be elevated, and in renal failure can be elevated. Stimulation from the chest, nipple stimulation included, local trauma can inhibit the dopamine as drugs. In a similar way, drugs can affect estrogens. Hypothyroidism, hypoadrenalism can cause problems related to TRH. And of course, if there's stock problems, it can inhibit the prolactin secretion. And as I mentioned, renal disease, liver disease, and sometimes it's the molecules of prolactin that influence. So, if you were to summarize them, these are the common causes of hyperprolactinemia. If you sort of correlate this with this pathophysiology, then you begin to understand that at different levels, prolactin can be elevated. Well, this may seem a little bit confusing. The easiest way perhaps to remember is that hyperprolactinemia can be due to pseudo-hyperprolactinemia. This is a laboratory artifact. It could be physiological, that's at the chest level, breastfeeding, for example. It could be pregnancy, due to estrogens. It could be pharmacological, and it could be pathological. So, in summary, if you recall, it's the 5 piece of hyperprolactinemia that is worth remembering. Now, I've done pathophysiology. Now let's move into clinical presentation. What I've tried to summarize is the epidemiology available from the world literature. I do appreciate different countries, there might be a slight difference, especially in presentation. These are huge studies done in UK, Europe, and America. And the percentage of pituitary adenomas, we're not talking about prolactinomas, but pituitary adenomas in the population is less than 1% of the population. Percentage of prolactinomas is pretty high, close to 50% if you look at the data. And estimated prevalence of prolactinomas per 100,000 population can vary anywhere between 35 to 63 per 100,000. So it's pretty common, and probably I'm missing some of these in the early stages particularly. Prolactinomas and microprolactinomas, they can be macroprolactinomas, and in males, females and males, the presentation may be slightly different, as our chairperson said. So in females, the early stages represented anovulation, oligogonorrhea, vaginal dryness. Males tend to present with decreased libido, they don't seek attention early, erectile dysfunction, gynecomastia, and common to both groups are weight gain, hypogonadism, delayed puberty in adolescents, infertility, galactorrhea, osteopenia, and osteoporosis. So, you'll find that those with a macroadenoma tend to present headaches, visual field defects, cranial neuropathy, and this is related to the close proximity of the pituitary to the cranial nerves. Women, of course, can present with two natural phases of fluctuation in estrogens. That will be pregnancy and menopause. Males, by and large, tend to present more with macroadenoma and space-occupying effects and anatomical manifestations, if you like. This is a study where one looked at tumor diameter and the prolactin level. Note that both of these are logarithmic axes, and if you look at this data, the males in darkest box are predominantly macroadenomas. Females are often microadenomas, but they can overlap. So that's useful to know. And that's because women have menstrual manifestations to manifest early. So that's the clinical presentations. Now, I want to highlight a little bit about diagnostic traps. So, in considering diagnostic traps, what do we do in refining prolactin? There are four important considerations first. Firstly, we have to ensure it's not done very soon after a breast examination or extreme stress. If in doubt, you can repeat a prolactin in a non-stressful situation, non-breast examination state. You of course history exclude drugs. Consider the possibility of pregnancy and its previous hypothalamic pituitary injury. One might consider that as a cause of prolactin. If one is unsure of pregnancy, one will do a HCG. Consider at least clinically whether there is primary thyroid or primary adrenal disease. If I'm sure that if not TSH, the ACTH cortisol may be considered. And then I want to highlight a good clinical history and examination is still essential. And then, if the prolactin is high, we have to tie back with the clinical presentation of this patient. Let me bring you through this in a little bit more detail. This is a visual framework model of what we expect prolactin levels in different situations. Again, this is a logarithmic axis in nanograms per ml, and that will be the normal range, women about 25, men about 20. If you use the other units, it's 500. Most macroadenomas have very high prolactin values. Microprolactinomas have lower values. There's an overlap. And this is well illustrated by the tumor size and the prolactin level. Seems to be a linear relationship. But if you look at macroadenomas, most of them very high prolactin. Yes, some of them may not have so high. In the same way, microprolactinomas generally lower, occasionally higher. So it's a rough guide. These are pseudoprolactinomas, meaning they behave like prolactinomas, but they're actually missing the stalk. This is in pregnancy. There's an overlap between micro and pro. That stress levels go a little bit high, and that's pharmacotherapy, particularly antipsychotics. So if you realize, at about 10 times normal value, you can sort of safely say this is likely a prolactinoma, and this is more likely a macro hormone. Now, once you have got this, then we look at symptoms. Some people have no symptoms, no clinical features. Prolactin is high. Some have overt clinical features, yet the prolactin is not so high. Some have overt clinical features, and the prolactin is very, very high. If it's very, very high, then overt clinical features. Yes, we can confidently diagnose a prolactinoma, and usually it's a macroadenoma. But if there's clinical features, slightly high prolactinomas, then you start thinking, could this be a non-functional tumor? That's pseudoprolactinoma stalk compression. Or the prolactinoma is not very efficient at producing prolactin, for example, cystic prolactinomas. Or is there a effect, a concomitant effect in the short arm? It could be sometimes a microprolactinoma. But if there are no overt clinical features, then you have to consider a macroprolactinemia, which is a laboratory effect, maybe a non-functioning tumor even. In order to exclude macroprolactinemia, we do PEG precipitation. To exclude hook effect, we measure prolactins in dilutions. I will talk a little bit about the hook effect run through. This is about 5% of patients with microadenomas. So we do a normal two-side immunometric assay where the prolactin is bound by two antibodies, the capture and the label detection antibody. Prolactin elevated, antibodies bound, and therefore the signal is high, the prolactin is measured high. When the prolactin gets higher, what happens? The signal goes up, it doesn't go any much higher, but the prolactin is very, very high. You may get a false low prolactin, and this is what we call the hook effect. The hook is there. And so you get a falsely low prolactin, the best way to resolve is tell your labs to do the prolactins in dilution. So I've done the hook effect, Now I'm going to talk about macroprolactinemia. Macroprolactinemia is common enough in 10 to 25% of the population. We measure hyperprolactinemia, but we don't have a real problem with prolactin. That's because our natural prolactin in our body, there are three types. There's monomeric, dimeric, also called prolactin, and IgG-bound prolactin. That's different molecular sizes. This is the majority and active, but these are not biologically active. They're immunologically active. That's why we measure them. And that's the majority of them. It's a minority, different studies, different indications. And that gives false results of hyperprolactin. So one must be careful when there's hyperprolactin. The patient has no symptoms. You have to consider it. And the best way the labs can do the PG precipitation. When they precipitate it by phospholipid glycol, the results may show a much lower prolactin, and therefore we know, oh, this is not real prolactin. So, I've gone through these important aspects that can cheat us sometimes, and what are the tests we could do to overcome being misled. Then, if we are very confident this is prolactinoma, then we do an MRI. Here comes my fifth point. We have to correlate prolactin with the MRI. Let me bring you some slides to illustrate this. This is a huge study, 456 hyperprolactin patients with or without radiological evidence of a pituitary tumor. They divide them into females, males, normal on MRI, microprolactinoma on MRI, macroprolactinoma. What you see a trend. High we tend to think macroprolactin, macroadenoma. The trend goes up. So you can't see a pituitary tumor prolactin, and it's to be a little bit low. So in summary, ensure don't do it after breast examination, stress, exclude, consider thyroid disease, correlate clinically, correlate with MRI. That way we avoid the traps. The next point I want to talk about is management decisions. When we want to treat patients, they are diagnosed prolactinoma confidently, you can observe that, or medical, surgical, radiation treatment. How do we decide? We decide whether they are symptomatic, micro or macroadenoma. We want fertility or not, special circumstances, pregnancy, menopause. We may decide not to treat this group yet. Of course, if it's a micro, we have a tendency to watch them if they are asymptomatic. That could well be incidental finding. But if it's macroadenoma, even if it is asymptomatic, we want to treat them. The goals of treatment, if you just want to treat, normalize the prolactin, decrease the tumor size, restore gonadal function. The hypogonadal patient may benefit, females from estrogen, males from testosterone, in addition, at least temporarily. The choice of treatment depends on what the patient wants, but the patient must be informed of the consequences of not treating what we observe. If they are progressive symptoms, sure, we want to treat. If they are comorbidities, then you begin to worry a little bit because your dopamine antagonists can aggravate psychiatric condition. Of course, if the tumor invades, you want to consider preventive treatment. And this is the normal staging of pituitary tumors, depending on how far they infiltrate the carotid beyond, on, and before. And generally, one rethinks about the treatment at different circumstances. So be prepared to review. For example, as I'll show you later, in the menopause, you may decide not to treat with a microprotector. Now, let's talk a little bit about bromocriptine, medical treatment. Bromocriptine and carbapenem are mostly used in clinical practice worldwide, but like pinacolide, nisuride are much less frequently. In some countries, they are no longer available. The way they act, it binds to the D2 dopamine receptor, and then the downstream effects after activating G-coupled GS-alpha receptor proteins, and they decrease the hormone secretion, they decrease gene expression, cell proliferation, and promote electrical cell death. Carbapenem has been strongly recommended as a treatment of choice, but let's not forget that there are no head-to-head comparison studies large scale, and cost becomes a big issue because carbapenem is much more expensive. Bromocriptine has a side effect profile that's pretty high. Patients get nausea, dizziness, nasal stuff, constipation. It can be minimized though by taking with meals. Start low. I often start with a quarter tablet, go slowly and build up. It's definitely much cheaper. Carbapenem has a much lower side effect profile. It's taken weekly. But let's not forget, in males, sometimes they get a big problem. They become hypersexual, they become impulsive, and expensive. And of course, in high dose, long-term use, cardiac monitoring as we recommend. Not routine for the doses we use in carbapenem. The studies are reassuring the dose is low. In pregnancy, females may not recognize that they are pregnant after treatment, so if they're not prepared for it, let them know that they may require barrier methods. During pregnancy, and to stop the agonist, the risk of increased size is mainly in microprolactinomas can resolve on its own postpartum. At treatment duration, we used to think it's lifelong, but now there's good evidence to say maybe it's not lifelong anymore. You can treat them 2 years, consider stopping, and this is based on the data where they look at 2 years treatment, stopping it. If there is macroprolactinoma, it can recur more often, microprolactinoma even less, and when you can't see a pituitary tumor, the recurrence rate is very low. These are newer drugs. I won't spend too much time on it, but just to tell you, they are coming as alternatives for resistant prolactinoma. For resistant prolactinomas, currently, we consider surgery. Like I said, if the North grading is more than equal to 2, surgery is not likely to be successful. So you need an experienced neurosurgeon. The success is in 93% for microprolactinomas if the patient wants it. But the recurrence occurs. So we can offer it to those intolerant, resistant, offer to young females who prefer this choice. But remember, 10% recurrence in microprolactinomas. Move on to radiation. It's reserved for those who are less shrinkage, non-resectable, steroid techniques are coming in, and patients should be advised to response takes several years. I'll quickly move to subgroups. I want to address 8 subgroups. Patients with empty cellular can have a prolactinoma. I'll deal with these three separately. In adolescents with prolactinoma, studies have few that do consider mutations in the AIP and in 1 gene. If there's familial prolactinoma, again, don't forget NAM1 or the other entity we more recently recognized, familial isolated pituitary NAM without NAM1. Some prolactinomas secrete growth hormone, prolactin, glycoprotein. So there may be more than one hormone, so it may not just be one prolactin hormone. Cystic prolactinomas, I mentioned earlier, usually are not so efficient. And unlike what was thought, do give dopamine packages. There may be some prolactinomas which operate tumors. We find that they stay positive, but clinically they don't appear to give significant findings. And rarely, malignant prolactinomas. I want to touch on these three now. Antipsychotics increase prolactin. So prolactinoma patients can be on psychotics also. Dopamine aggravated. So when you use dopamine antipsychotics, they get into problems. Treatment options, these are the drugs that may increase prolactin, no effect or minimal effect, and in pregnancy, prolactin goes up. Look at the data at 3 different trimesters. Look at the trend. It goes upwards as the trimester goes up. And more so in macroprolactinomas. Patients with prolactinoma have fertility issues and they undergo assisted reproductive technology treatment, and therefore they may become pregnant. Microadenomas don't increase in size, we can stop. In macroprolactinomas, we tend to stop and observe. In menopause, it tends to resolve spontaneously because there's no more estrogen is moved into menopause. So you can consider stopping treatment. Current evidence does not support treating asymptomatic microprolactinomas in women. In postmenopausal stage, if it's macroadenoma, yes, you want to treat it. Micro, you may miss. So I've gone through the subgroups. I want to round off with some summary pointers. First, prolactinomas are the commonest pituitary tumors. Epidemiological studies suggest prevalence is close to 50 per 100,000 different populations. When you see a high prolactin, it does not equate prolactin. Make sure we are not missing out laboratory artifacts, drugs, physiological causes, or even pregnancy. Prolactinoma manifestations are variable in males and females. They are very dependent on tumor size. Macroadenoma tends to give more atypical manifestations. If you find discordant clinical and prolactin or discordant prolactin and MRI, the antenna goes up and you start thinking of non-functional tumors. Medical treatment is the first line. Treat for 2 years. You may consider surgery, but you must understand there's a recurrence rate. And that is important for them to know and decide that. Psychiatric patients can have prolactinomas too. Particularly it is very hard for them. In childhood prolactinoma, consider familial genetic aspects. If a patient becomes pregnant and delivers after that, consider checking the prolactin. You do not need to treat them because some of them infarct after pregnancy. And lastly, in menopause consider stopping the treatment because prolactinomas may regress? Terima kasih.